All right, so we're back for another deep dive. This time, flexor and extensor tendon anatomy, injury, and repair. It's a pretty meaty topic, right?
Yeah.
But absolutely essential for the FRCS plastic surgery exam.
Yeah, definitely. And I think regardless of what stage of residency you're at, this is something that you should be able to, kind of come back to and solidify those concepts.
And that's exactly our mission here, right? To sort of cut through the noise and just focus on what really matters, those high-yield points.
Yeah, exactly. So we're not going off on tangents or anything, focusing on things you can actually apply on exam day.
So let's get straight into it. Let's start with flexor tendons. Could you remind us, what are the main muscles involved in, finger and thumb flexion?
Sure. So the main flexor muscles are the flexor digitorum profundus, or FDP, the flexor digitorum superficialis, or FDS, and the flexor pollicis longus, or FPL.
Right. And the FDP and FDS, they have that key anatomical difference. Can you tell us about that?
Yeah, so the FDS, it actually originates from a common muscle belly in the forearm, whereas the FDP, each of those four tendons, actually comes from its own independent muscle belly.
That's right. And talking about the FDS, its path in the fingers is pretty interesting. It kind of has a special characteristic, right?
Yeah, that's right. At the level of the metacarpal head, each FDS tendon splits, and this is at a point called Camper's chiasma. And then these two slips, they actually pass around the FDP tendon, and then they reunite again deep to it. And then from there, they insert separately onto the volar aspect of the middle phalanx.
Right. And there's a clinical point to remember about the FDS, isn't there? Something with the small finger.
Yeah, that's right. So the FDS tendon to the small finger can actually be congenitally absent in about 15% of people. So that's something to keep in mind when you're examining patients.
Absolutely. Okay, so that's the FDS. What about the FDP and the FPL? Where do they insert?
So the FDP inserts on the volar base of the distal phalanx of each finger. So it's responsible for flexing that DIP joint. And the FPL, as its name suggests, it acts on the thumb. It inserts on the volar base of the distal phalanx of the thumb, so it flexes that IP joint.
Perfect. And what about the nerve supply to these flexor muscles? It's a common exam question.
Yeah, definitely. So the FDS is innervated by the median nerve. The FDP is actually a bit more complex. It has dual innervation. The index and the middle fingers are supplied by the anterior interosseous branch of the median nerve, whereas the ring and small fingers, they get their nerve supply from the ulnar nerve. And then the FPL is solely innervated by the anterior interosseous nerve.
Great. And of course, these tendons, they're not just, floating around in the hand. They're enclosed within a special structure, right? What can you tell us about the flexor tendon sheath and its components?
Yeah, so the flexor tendons are all enclosed within what we call a synovial sheath. This is essential for, it allows them to glide smoothly without friction. It's also really important for nutrition of the tendons. And this sheath is reinforced by a series of pulleys. So we have 5 annular pulleys. They're designated A1 to A5. And then we have 3 cruciate pulleys, C1 to C3. And, just to remember the location of the annular pulleys, the odd-numbered ones, so A1, A3, and A5, they're actually located at the level of the joint. So the MP, the PIP, and the DIP joint, respectively. The A2 pulley, that's on the proximal phalanx, and then the A4 is on the middle phalanx.
Right. And there are 2 of these annular pulleys that are particularly important, clinically speaking, right? Which ones are those and why?
Yeah, the A2 and the A4 pulleys. These are crucial for preventing what we call bowstringing of the flexor tendons when you flex your finger. So if those pulleys are damaged or, they're not functioning properly, it can lead to a real loss of grip strength and overall hand function. The thumb actually has a slightly different pulley system. It's got the A1, the A2, and then an oblique pulley. And that oblique pulley is really important to prevent bowstringing of the FPL.
Makes sense. Now, another common exam topic. How do these tendons actually get their nutrition, inside this confined space of the sheath?
So the flexor tendons actually have 3 main sources of nutrition. So they get direct vascular supply from the myotendinous junction proximally, and also from their bony insertions distally. Then they also have these structures called vincula, which are like small little fibrovascular folds. They carry branches from the digital arteries and insert dorsally into the tendons. So for the FDS, we have the vinculum breve superficialis, or VBS, and the vinculum longum superficialis, or VLS. And then for the FDP, we have the vinculum breve profundus, or VBP, and the vinculum longum profundus, or VLP.
Right. And that dorsal insertion of the vincula is an interesting point, isn't it?
Yeah, it's thought that because the vincula enter dorsally, if we place our sutures on the volar aspect of the tendon during repair, it might minimize the disruption to that blood supply.
Okay, that's interesting. And what about the synovial fluid itself? Does that play a role in tendon nutrition?
Yeah, absolutely. The primary source of nutrition for the tendon within that sheath is actually diffusion from the synovial fluid.
Makes sense. Okay, let's move on to the Verdun zones, which are obviously, super important for classifying flexor tendon injuries. Can you quickly go over the different zones, both for the fingers and the thumb, and explain why this classification is so important clinically?
Sure. So for the fingers, we have 5 zones, zone I to zone V. Zone I, that's the area distal to the insertion of the FDS, so on the middle phalanx. Zone 2, sometimes called no man's land, lies between the A1 pulley and the FDS insertion. And this zone is, it's historically been known for having poor outcomes after repair because it's such a tight space and there's a pulley system there. Zone 3, that extends from the distal edge of the carpal tunnel to the A1 pulley. Zone 4V, that's within the carpal tunnel itself. And then zone V is proximal to the carpal tunnel in the forearm. Now for the thumb, we have 5 zones as well, TI to TV. Zone TI, that's distal to the IP joint. Zone T-tie between the A1 pulley and the IP joint. Zone T3, that's over the NAR eminence. Zone TIV is within the carpal tunnel, and then zone TV is proximal to the carpal tunnel. And this Verdun classification is really important because it helps us to understand the different structures that are at risk with each injury, and also the technical challenges of repairing a tendon in each of those zones can be quite different.
Absolutely. So let's say we have a patient coming in with a suspected flexor tendon injury. What are the key things you're looking for in your clinical evaluation, especially during the physical exam?
Okay, so first and foremost, you need a really good history. So how did the injury happen? What was the position of the hand at the time of injury? Those things are really important. Then, a really thorough physical exam is crucial. Start with the vascular status of the digit. You might need a Doppler if you're concerned. Look at the resting posture of the hand. That can give you some clues as well. And really importantly, a good neurological exam, including 2-point discrimination, and do this before you give any local anesthetic.
Yeah, that's really important, isn't it? Because the anesthetic can obviously affect your sensory testing.
Exactly. Then you want to isolate and test each tendon individually. So to test FDP function, you need to block flexion at the PIP joint so you can isolate movement at the DIP joint. And for the FDS, you stabilize the adjacent fingers in extension so you can overcome that common muscle belly and test for isolated PIP joint flexion.
Right, and there are a couple of anatomical variations we need to keep in mind, right? Things that might, kind of throw us off during our exam.
Yeah, so remember that the FDS tendon to the small finger can be absent, and that happens in about 15% of people. And then there's also something called Lindbergh's syndrome, which is where you have this anomalous connection between the FPL and the FDP of the index finger, and that's seen in about 30% of people. So both of these can affect your tendon testing.
Good point. Anything else essential on the physical exam?
Oh, and always get hand radiographs. It sounds obvious, but it's important to rule out any associated fractures or foreign bodies.
All right, so we've made the diagnosis, we've got our x-rays. Now, the question is, when do we operate? Are all flexor tendon injuries surgical emergencies?
Not necessarily. The main indication for emergency repair is actually digital devascularization. So if the blood supply to the finger is compromised, then you need to go to the OR straight away. But primary repair, ideally within 24 hours, is generally preferred when it's possible.
And what are some of the contraindications to doing a primary repair?
So contraindications would include heavily contaminated wounds, like, for example, a human bite, also active infection, or if the soft tissues around the injury are in really bad shape.
So what do we do in those situations where primary repair isn't appropriate?
Well, you might consider doing a delayed primary repair. This is usually done between 24 hours and up to 2 weeks after the injury. It can be a good option if you have a contaminated wound that needs time to be properly cleaned and, for any signs of infection to settle down.
Got it. And what about secondary repair? When do we do that, and what are the different types?
So secondary repair is basically anything after that initial 2-week window. We can divide it into early secondary repair, which is usually done between 2 and 5 weeks after the injury, and late secondary repair, which is anything after 5 weeks.
And what are the implications of choosing one over the other?
Well, with early secondary repair, you can often still mobilize the tendon ends without too much difficulty. Before you get really bad scarring and retraction of the muscles. The results can actually be comparable to a delayed primary repair in some cases. But obviously, as you delay the repair, you do increase the risk of infection and things like prolonged swelling. And with late secondary repair, after 5 weeks, things get a lot more challenging because by that point, you've got established tendon retraction, you've got scarring in the tendon sheath, you might even have some muscle contracture. So often, you need to think about tendon grafting or tendon transfers in those situations.
Right, that makes sense. And there's a limit to how much you can advance the FTP tendon, right,
Yeah.
to avoid a certain complication.
Yeah, that's right. You generally don't want to advance the FTP tendon more than about a centimeter.
Mhm.
If you do, you can get something called the quadriga effect. This is where flexion of one finger is limited because the other FTP tendons are tethered.
Okay, good to know. Now, you mentioned tendon grafting, which is obviously a really important technique, especially in these more complex reconstruction situations. When do we typically use tendon grafting, and what are the different options for donor tendons?
So we typically use tendon grafting when there's segmental loss of a flexor tendon. So a portion of the tendon is missing. Or if there's significant muscle contracture and you just can't do a direct repair. For a single-stage tendon graft, you need a few things to be in place. The tendon sheath needs to be relatively intact, the pulley system needs to be working, you need good soft tissue coverage, and the joints need to be supple. And if those things are all okay, then you can do the graft in one go. For donor tendons, we commonly use the palmaris longus, the plantaris, and the extensor tendons from the toes.
And what if the tendon sheath is damaged or the pulleys aren't working properly?
Then you might need to do a two-stage procedure. So the first stage involves removing the damaged tendon, reconstructing any pulleys that are deficient, and then inserting what we call a hunter rod. It's a silicone rod, and it's basically used to create a pseudosheath. So over time, fibrous tissue grows in around the rod. Then in the second stage, usually a few months later, the tendon graft is threaded through this new pseudosheath and attached to the proximal and distal stumps of the original tendon.
Wow, that's pretty incredible. And how do you actually attach the graft? Are there any specific techniques for that?
Yeah, so proximally, we often use a pulver taft weave, which is a very strong technique. And then distally, you might use a pull-out suture to a button on the nail, or you might use a suture anchor fixed to the bone. And you have to be really careful with the tension on the graft. If it's too tight, you can get problems like the lumbrical plus finger deformity.
Right, that makes sense.
Yeah.
Now let's talk about the actual surgery itself. What are some of the fundamental principles that guide us when we're doing a flexor tendon repair?
Okay, well, first of all, precision is really important. So we always use loop magnification. And your incision, whether it's a midlateral incision, a Brunner incision, or you're incorporating the original laceration, it needs to give you good exposure, but you also have to make sure you have viable skin flaps. And, we try to minimize handling of the tendon itself because that can increase the risk of adhesions.
And there's a trick to remember about the skin laceration, isn't there?
Yeah, so the skin laceration doesn't always line up directly with the tendon injury. It's because of the way the hand was positioned when the injury happened. So you have to keep that in mind when you're exploring the wound.
Okay, good point. And in terms of the repair itself, how do we choose the right suture technique and how many strands do we use?
So the initial strength of the repair actually depends on how many strands of suture are crossing the repair site. So more strands equal more strength. And generally speaking, locking core sutures are stronger than simple grasping sutures. If you're doing early active motion, you need at least a 4-strand core suture repair. We also like to use a running epitendinous suture, usually 6-0 or 7-0, and that's just to improve the strength of the repair and make the repair site smoother, which might help to reduce adhesions. And each core suture should ideally extend about 10 millimeters on either side of the laceration.
What about the pulver taft weave? When do we use that?
The pulver taft weave gives you excellent strength, but it can be a bit bulky, so we tend to reserve it for tendon grafts, tendon transfers, or repairs in zones 3 and V, where the extra bulk isn't such a big problem.
Okay, that makes sense. Now, what about partial tendon lacerations? Do we always repair those?
It depends. If the laceration involves more than 50% of the tendon, then we usually repair it with both core and epitendinous sutures. And we also repair oblique lacerations because they can catch on the pulleys.
Right, good point. So let's talk about some of the specific considerations for each zone. Let's start with zone I injuries.
So zone I, this is distal to the FDS insertion. So usually it's just the FDP tendon that's injured. If it's a sharp laceration, the vincula often hold the proximal end of the tendon in place. But you need to check for any injury to the volar plate of the DIP joint and repair that if necessary. And for the distal FDP stump, you need to make sure you've got at least 5 millimeters of tendon to work with. If you don't have enough, you might need to reinsert it using a pull-out suture or a suture anchor at the distal phalanx.
Okay, what about avulsion injuries?
Yeah, so avulsion injuries in zone 1, these are commonly called rugger jersey finger, and they're classified according to the Letty classification. So type 1, the tendon retracts all the way into the palm and both vincula rupture. Type 2, the tendon retracts to the PIP joint and the long vinculum is still intact. Type 3, you've got avulsion of a bony fragment that prevents retraction beyond the middle phalanx. And type 4 is a combination of tendon and bony avulsion with significant retraction. The treatment really depends on the specific Letty type.
Right, that's quite a bit to remember about zone 1. What about zone 2, the dreaded no man's land?
Yeah, so zone 2, historically, it's had a bad reputation for poor outcomes. But actually, acute repair is now the standard of care because our surgical techniques and rehab protocols have gotten much better. In most cases, we'll repair both the FDP and the FDS, unless the injury is really badly messed up. You need good exposure, so you have to be careful dissecting around the neurovascular bundles. And it's really important to preserve the A2 and A4 pulleys. So instead of cutting them, we might create windows in the other pulleys to help us retrieve the tendons and do the repair.
And what are some of the techniques for retrieving those retracted tendon ends?
Well, you can try to gently milk the tendon proximally, or you can use a reverse S-march bandage to kind of push the tendon distally. And sometimes you can pass a tendon retriever retrograde through a proximal incision in the forearm. The repair itself is usually a 4 to 6 strand core suture using non-absorbable suture, and then we add a running epitendinous suture to make it stronger and smoother.
Okay, what about zone 3? What are the key considerations there?
Zone 3, it generally has a better prognosis than zone 2. The tendons are a bit bigger here and you don't have the same constraints from the pulleys, so we can usually do a stronger 6 strand repair. Nerve injuries are more common in this zone, and they can really impact the final outcome, even more so than the tendon injury itself.
And zone 4, inside the carpal tunnel.
Zone 4, it's very similar to Zone 2 in terms of the technique. It's a very meticulous repair because of the limited space and all the important structures in that area. The one key difference is that we always repair the transverse carpal ligament after we've repaired the tendons. That's to prevent bowstringing.
And finally, zone V. What do we need to know about that?
So Zone V injuries, they tend to have good outcomes. The tendons are bigger here, so we can do really strong repairs, and that allows us to start early active motion. The main concern with Zone V is that you often get associated nerve injuries. And as I said before, the nerve injury can have a much bigger impact on function than the tendon injury itself.
All right, so let's move on to post-op care. What's the standard approach for immobilization and rehab after a flexor tendon repair?
Well, typically we use an extension block splint. So the wrist is positioned in about 20 to 30 degrees of flexion. The MP joints are flexed to about 60 to 70 degrees, and the IP joints are in near full extension or slight flexion. We usually keep the splint on until the sutures are removed, which is usually about 2 weeks after surgery.
Right, and what about rehab?
Early controlled mobilization is now the standard of care for most flexor tendon repairs. There are a few different protocols, like Duran and Hauser, which focuses on passive ROM and differential tendon gliding. The Kleinert protocol, which uses elastic traction to do passive flexion and active extension within the splint, and early active motion protocols, which are only really used for really strong repairs.
Got it. And what are some of the common complications we see after flexor tendon repairs?
The most common complication is rupture, which happens in about 5 to 10% of cases. The FPO actually has a slightly higher risk of rupturing. If a tendon ruptures, you need to go back to the OR and re-repair it. And if it ruptures again, then you might need to think about secondary reconstruction. You can use a tendon graft, a tendon transfer, or even do an arthrodesis in some cases. Another common problem is adhesions. This basically means that the tendon gets stuck down and it limits the range of motion. You can sometimes do a tenolysis to release the adhesions, but only if the passive range of motion is good and there's been no improvement in active ROM despite good therapy for a few months. And then you can also get contractures, which happen in about 15 to 20% of repairs. We treat contractures with splinting and therapy, and if that doesn't work, then we might need to do a surgical release.
Okay, so that's flexor tendons covered. Let's move on to extensor tendons. What are some of the general things we need to keep in mind when we're dealing with these injuries?
Okay, so in general, extensor tendon injuries are less likely to have associated nerve or vascular injuries compared to flexor tendons. That's because they're more superficial and they're on the back of the hand. Partial tendon lacerations are very common with extensor tendons because they're quite flat. And penetrating injuries in this area, they're more likely to involve the joints, which is something to watch out for. And post-op splinting and a good therapy program are really important for getting good outcomes after an extensor tendon repair.
All right, so let's talk about anatomy. We've got all those extrinsic extensor tendons, and they all pass under that extensor retinaculum at the wrist, which is divided into 6 compartments, right? Can you quickly remind us what's in each compartment?
Sure, so all of the extrinsic extensor muscles are innervated by the radial nerve. And at the wrist, the tendons pass under the extensor retinaculum, which is divided into those 6 compartments. The first compartment contains the abductor pollicis longus, APL, and the extensor pollicis brevis, EPB. The second compartment contains the extensor carpi radialis longus, ECRL, and extensor carpi radialis brevis, ECRB. The third compartment contains the extensor pollicis longus, EPL. The fourth compartment contains the extensor digitorum communis, EDC, to the forefingers, and the extensor indicis proprius, EIP. It's worth remembering that the EDC often has 2 slips to the ring finger, and the slip to the little finger can be absent in some people. The fifth compartment contains the extensor digiti minimi, EDM, which often has 2 slips as well. And finally, the sixth compartment contains the extensor carpi ulnaris, ECU. The ECU is unique because it has a true synovial sheath, and if it gets injured or becomes unstable, it can sublux and cause pain.
Okay, so that's the extrinsic muscles. What about the intrinsic muscles? How do they contribute to finger extension?
So the intrinsic muscles, they're really important for fine motor control, and they also help to extend the IP joints when the MP joints are flexed. So you have the dorsal and palmar interossae, and they're all innervated by the ulnar nerve. The dorsal interossae abduct the fingers, whereas the palmar interos adduct them. It's useful to remember DAB and PA. Dorsals abduct, palmars adduct. And both sets of interossae also help to flex the MP joints and extend the IP joints when the MP joints are flexed. Then there are the lumbricals. They originate from the FDP tendons in the palm, and they insert onto the radial side of the extensor hood. The lumbricals to the index and middle fingers are innervated by the median nerve, and the lumbricals to the ring and small fingers are innervated by the ulnar nerve. Their main function is to extend the IP joints, but they also weakly flex the MP joints. And just to mention, you can get this thing called lumbrical plus finger, which happens when there's too much distal traction on the FDP tendon.
Okay, that's great. Now, can you explain the extensor mechanism in the fingers, that whole trifurcation thing?
So distal to the MP joint, the extensor tendon kind of fans out and it splits into 3 parts: a central slip and 2 lateral bands. The central slip inserts onto the dorsal base of the middle phalanx, and it's the main extensor of the PIP joint. The lateral bands run along the sides of the PIP joint, and they get contributions from the intrinsic muscles. These combined lateral bands, they come together distally to form what we call the conjoined lateral bands, and then these unite to form the terminal extensor tendon, which inserts onto the dorsal base of the distal phalanx and extends the DIP joint.
Right. And what about the juncture tendinum and the sagittal bands? What do we need to know about those?
So the juncture tendinum, they're like little fibrous connections between the EDC tendons on the back of the hand. They're pretty variable in their anatomy, and they allow for a little bit of independent movement between the EDC tendons. Clinically, they can be a bit tricky because they can sometimes mask a complete laceration of a single EDC tendon. So you might think the tendon is intact because you still see some extension, but actually the extension is coming from the adjacent tendons through the juncture. The sagittal bands are fibrous structures that originate from the palmar plate and the intermetacarpal ligaments at the MP joint. They wrap around the EDC tendon and they help to form the extensor hood. Their main job is to keep the EDC tendon stable over the MP joint and to transmit the force of the EDC to the central slip, which helps with PIP joint extension. They also help to prevent the MP joint from hyperextending.
Okay, and just a quick word about the extensor digitorum brevis manus.
Yeah, so the extensor digitorum brevis manus, EDBM, this is an extra muscle that some people have on the back of the wrist. It's only present in about 3% of people. It originates distal to the extensor retinaculum and usually inserts into the extensor tendon of the index or middle finger. It can cause pain or a lump on the back of the wrist, especially with wrist flexion, and people often mistake it for a ganglion. If it's causing problems, you can just remove it surgically.
Good to know. Now, how does the healing process and the blood supply of extensor tendons compare to flexor tendons?
So extensor tendons, they get their blood supply from a few different sources. They have their own internal blood supply, they get some diffusion from the synovial fluid under the retinaculum, and they also get blood supply from adhesions that form during healing. Unlike flexor tendons, they don't have those special vincula structures, so their blood supply comes from the myotendous junction, the bony insertion, the peritoneum, and the mesotendon within the retinaculum.
All right, let's move on to the zones of injury for extensor tendons. Can you run through those again, both for the fingers and the thumb?
Okay, so for the fingers, we have 9 zones, I to IX. And for the thumb, we have 5 zones, TI to TV. A good way to remember the finger zones is that odd-numbered zones are over the joints, and even-numbered zones are between the joints. So zone on is over the DIP joint, zone 2 is over the middle phalanx, zone 3 over the PIP joint, zone 4 over the proximal phalanx, zone V over the MP joint, zone 6 over the metacarpals, zone 7 over the carpus, zone 8 over the distal forearm and extensor retinaculum, and zone 9X over the proximal forearm and muscle bellies. For the thumb, it's a bit simpler. Zone TI is over the IP joint, zone TI over the proximal phalanx, zone T over the MP joint, zone TIV over the metacarpal, and zone TV over the carpus and distal radius.
Okay, that's a good way to remember it. Now, are there any general principles we should bear in mind when we're repairing extensor tendons, regardless of the zone?
Yeah, so extensor tendons, they tend to be thinner and flatter than flexor tendons, which can make it a bit harder to get a good grip with the sutures. For the core suture, we often use a Kessler, a Bunnell, or a running horizontal mattress suture. And for the epitendinous repair, we usually use a running cross stitch with a fine, non-absorbable suture on the back of the tendon. Primary repair is what we aim for in most cases, unless the wound is really dirty, like with a bite injury. And distal to the MP joint, the extensor tendons don't tend to retract as much because they're held in place by the juncturae tendinum. And one important tip, when you're tying your sutures, especially if you're using monofilament, make sure you don't tie big, bulky knots because they can rub under the thin skin on the back of the hand.
Good advice. So let's go through the specific zones now, starting with zone I and mallet finger.
So mallet finger injuries, these are in zone 1 over the DIP joint, and we use the Doyle classification to classify them. Type 1 is a closed injury, type 2 is an open laceration, type 3 is an abrasion with some tissue loss, and type 4 is associated with a fracture. The treatment depends on the type. So type 1, we usually just treat it non-surgically with a splint that keeps the DIP joint in extension for 6 to 8 weeks. It's really important to keep the joint in extension the whole time. For type 2, we can do a primary repair with a fine suture followed by splinting. Type 3, we need to deal with the soft tissue loss first, and then we can address the tendon. And type 4, if there's a fracture, we might need to fix it with pins or do an open reduction and internal fixation, depending on the fracture pattern. Mallet thumb injuries, so this is zone TI, are treated in the same way with splinting or surgery if there's a fracture.
What about zone 2 injuries?
So in zone 2, if you have a partial tendon laceration that involves less than 50% of the width of the tendon, you can sometimes get away with just trimming the frayed edges and starting early motion. But if the laceration is more than 50%, then we repair it with a running core suture and an epitendinous suture. And then we splint the DIP joint in extension, but we let the PIP joint move freely. In the thumb, zone TII injuries, we repair them with a core suture and an epitendinous suture, and then we splint the IP joint, sometimes with a thumb spica splint for extra support.
Now, zone 3, that's over the PIP joint, and we need to talk about boutonniere deformity, right?
Yeah, so zone 3 injuries, if the central slip is disrupted, you can get a boutonniere deformity. And closed central slip injuries, they're often missed initially, so you need to have a high index of suspicion. The classic signs are swelling and tenderness over the middle phalanx, weakness of active PIP joint extension, but the passive extension is okay, and the finger is held with the PIP joint flexed and the DIP joint hyperextended. If it's a closed injury, we treat it with a splint that holds the PIP joint in full extension for 6 weeks, and then we start active flexion exercises. Sometimes we use a K-wire to temporarily hold the PIP joint straight. If it's an open injury, we repair it with a core suture and an epitendinous suture. And it's really important to irrigate the joint thoroughly if the capsule has been open, and then the post-op splinting is the same as for a closed injury. The main goal here is to prevent a fixed boutonniere deformity, because if it becomes fixed, the secondary surgery to correct it is much more complex. For thumb injuries in zone T3, we repair them with core sutures and then splint the wrist and thumb in extension for about 3 weeks, and then start gentle motion exercises.
Okay, zone 4, over the proximal phalanx.
So zone 4 injuries often involve the central slip and the lateral bands. If you need to repair the central slip, you use a core suture and an epitendinous suture, and you have to make sure you don't shorten the tendon. The splint for zone 4V is wrist extension, MP joint flexion, and IP joint extension. If it's just one of the lateral bands that's injured, you can often repair it with a simple epitendinous suture. Thumb injuries in zone TIV are treated in the same way as zone T injuries.
And what about zone V, over the MP joints?
Zone V, you have to be really careful with open injuries here, especially if it's a fight bite. Fight bites are notorious for getting infected, so always get x-rays to look for any foreign bodies. And you have to debride and irrigate the wound really well. If you're worried about infection, you can leave the wound open to heal by itself. If it's a larger laceration and there's no infection, we repair it the same way as a zone 5 injury. And just to mention sagittal band injuries, which can happen in zone V. If the sagittal band is torn, the extensor tendon can sublux. If it's an open injury, we repair it with a cross-stitch suture and then splint the MP joint in extension and buddy tape it to the next finger. Closed sagittal band injuries are usually treated with a splint that blocks MP joint flexion, but if it's a chronic problem, they might need surgery. Thumb injuries in zone TV, again, similar repair to zone T3, but if the APL tendon is really retracted, we might need to reattach it near its insertion on the thumb metacarpal.